As we all know, the world is generally getting bigger. You just have to look around in the shopping centre to see that people are generally bigger. Australia has about 60% of our adult population are overweight or obese, and that's been steadily increasing over the years. With increased weight comes the risk of weight-related comorbidities, such as diabetes, obstructive sleep apnea, cardiovascular disease. There's also some interesting data linking weight to certain forms of cancer. The other side of the coin is that some people have said, look, I have a weight issue, but I don't have any of those diseases, so I don't need to worry about my weight. There's been an interesting study just published out of the UK. They had over 300,000 patients that they followed up for 11 years. And that study showed that if you got a BMI of over 30, but were otherwise healthy, you still had an increased all-cause mortality. You were 4 times more likely to become diabetic in time. You're twice as likely to develop heart failure, and you also had an increased risk of things like strokes, heart attacks, developing respiratory disease, even if you had a normal blood pressure, normal blood sugar, and normal cholesterol. Interestingly, they compared the patients with a BMI of over 30 who were healthy to patients with a normal BMI who were unhealthy, who had diabetes, high blood pressure, high cholesterol, and the obese healthy patients had a worse mortality risk. So it appears that it may not be possible to be overweight and healthy in the long term. Type 2 diabetes is the fastest growing epidemic that we've ever had in the world, faster than HIV, faster than cholera or typhoid in the past, and yet we don't see any adverts from the government about it. With type 2 diabetes comes risk of eye problems, kidney problems, heart attacks and strokes. It's obviously something that I feel fairly passionate about, because if we intervene early with weight loss surgery, we can have fairly spectacular results in terms of resolution of type 2 diabetes. Depending on how long you've been a diabetic and depending on which operation you can have up to an 85-90% resolution in your type 2 diabetes. Traditionally, bariatric surgery has been seen as the option of last resort after you've failed all other forms of weight loss. However, increasingly the diabetic associations around the world are saying that if you're a newly diagnosed diabetic and you haven't hit your metabolic targets, your HbA1c, your cholesterol, your blood pressure targets within 12 months of diagnosis, you should really consider bariatric surgery. And I think that's something that we should be doing more of. We should be seeing more diabetics because the results are so good. I say to my medical colleagues, if I was a pharmaceutical rep and I was saying this drug will cure 85% of your diabetics, everybody would be prescribing it, and yet we don't see very many patients referred for bariatric surgery from a diabetic clinic. In addition to diabetes, obesity is associated with respiratory and cardiovascular disease. Your risk of stroke and heart attack is increased, your risk of heart failure is increased. And there are increasing studies now showing that relatively modest degrees of weight loss, 10-15% of weight loss, can significantly improve cardiovascular function and obstructive sleep apnea. Obstructive sleep apnea is something that, again, we're fairly passionate about. We look for it on a regular basis as part of our workup. The reason for that is several-fold. First of all, if we can treat your obstructive sleep apnea, it reduces your anesthetic risk should you proceed with surgery. And in addition, untreated obstructive sleep apnea has a metabolic effect and makes it harder for patients to lose weight. There's been studies that showed that in addition, patients with obstructive sleep apnea have an increased all-cause mortality over time, and most people who have heart attacks have undiagnosed sleep apnea. So these are comorbidities that we're very keen to identify and treat if possible, and obviously if you proceed with surgery and you lose significant amounts of weight, they can disappear altogether. The other thing that's become increasingly interesting and studied in recent years is the link between obesity and some forms of cancer. For example, endometrial cancer or uterine cancer in women, it's virtually impossible to develop it without being obese. There have been links to colon cancer in men, esophageal cancer and renal cancer. So there's been a lot of research on this, and again evidence that if we can reduce your weight, then we reduce your risk not only of mortality from cardiovascular events such as heart attacks and strokes, but also from certain forms of cancer. Traditionally, bariatric surgery has been formed as an open operation and had a relatively high risk. That's now been changed by the fact that we perform it laparoscopically or keyhole surgery. It's usually a couple of days in hospital. It's generally not a very painful operation. And the mortality of bariatric surgery is similar to having your gallbladder out, and most people wouldn't think twice about having surgery to have their gallbladder out if their doctor felt that was indicated. In addition, the traditional guidelines for bariatric surgery were a BMI of over 40 with no comorbidities, or a BMI of 35 with a comorbidity such as diabetes. Again, those were formulated in 1999 when we did it as an open operation, and there have been several studies now showing that in fact patients with a BMI between 30 and 35 probably do the best in the long term with weight loss surgery. So most surgeons around the world are operating on patients at lower BMIs without necessarily any comorbidities. The other issue with BMI is that it's not perhaps the best indicator. So some people with a lower BMI will have nasty diabetes, whereas other people who are heavier may not. And then also it doesn't allow for ethnicity. There's clear evidence that in Asian communities, they tend to develop the comorbidities associated with weight at a much lower weight, and therefore they should be having surgery at a lower BMI. So we offer a multidisciplinary approach to surgery or to weight loss with dietitian psychology support. If you're interested, and if you're maybe a bit unsure as to whether or not you would qualify, feel free to contact the practice. We do offer a free consultation with Shirley, the practice coordinator, who can discuss the various options available to you, both surgical and non-surgical, depending on your BMI and your comorbidities.